So our case is a 63-year-old woman with bipolar disorder, cancer, and worsening depression. My name is Amy.
I'm Sandra.
And I'm Charlee Manigat. And our presentation is less about this patient's symptoms and diagnoses, but more about how difficult it is to manage a cancer patient battling with their already pre-existing cancer along with a mental illness. So with this case, we also observe how barriers to treatments cancer patients with mental illness creates and how it's difficult to maintain treatment and things like that. So Mass General psychiatrist Daniel J. Donis reported after conclusive examination that a 63-year-old woman with bipolar disorder, worsening depression, and multiple medical problems in addition to lung cancer and breast cancer was admitted to inpatient psychiatry service at this hospital for electroconvulsive therapy. And his team reported a similar presentation to ours about this patient and her story. Just to provide some family background on this patient, a lot of information was made known to us, but due to privacy reasons and protocol, a lot wasn't. But what was really interesting. So her father was known to be abusive towards her during her childhood and possibly her mother as well, but he died from leukemia in his early 50s. Her mother died from a myocardial infarction, which is just a heart attack, in her early 50s. Her paternal grandfather died from stomach cancer in his 60s, and the rest wasn't really known. But the main point to make about this limited family tree is that a lot of her immediate family members died at an early age from serious illnesses, but there wasn't really any history of lung or breast cancer, so that's interesting. Also, this patient was married to a husband at the time of her admission, and he was also battling mental illness. And they had a child as an adult now, but they gave that child up for adoption. We don't know the name or gender of this child. So a little social history is that they also are reliant on disability assistance, so that puts a strain on their already stressful lifestyle. This patient had quite a list of poor health habits. So first off, she was a heavy smoker and she smoked about 1 to 2 packs daily for 40 years. She admitted to occasionally using cannabis, cocaine, and hallucinogens. However, she never took part in any intravenous drugs, and she wasn't really an alcoholic. She was also known to have suffered through a lengthy list of other ailments aside from her cancers, consisting of COPD, hypertension, restless leg syndrome, which is associated with her long-standing anxiety. She had a long-standing history of bipolar disorder, ADHD, asthma, pulmonary disease, and insomnia. Since we are aware of her long-standing history of bipolar disorder, it's important to review her psychiatric history. So her bipolar disorder consisted of mania and depression, and her manic periods normally lasted from 1 to 3 weeks and were characterized by elevated moods, impulsive behavior, decreased need for sleep, and occasional psychosis consisting of hallucinations and paranoia. Contrastingly, her depressive phases were characterized by low energy and motivation, poor appetite, apathetic mood, and hopelessness. So here's just a quick timeline for hospital admission. So she did visit the hospital quite a few times. So in 2004, she was diagnosed with stage 2 invasive ductal carcinoma of the left breast, which spread to her lymph nodes, which resulted in isolated tumor cells in 2 lymph nodes. So for that, she underwent a lumpectomy, chemotherapy, and radiation. In 2014, she was diagnosed with stage 2 lung adenocarcinoma, and for that, she underwent an upper right lobe lobectomy and chemotherapy. And recently, in 2015 to 2016, she was experiencing worsening depression and anxiety, and for that, she finally agreed to undergo ECT for refractory depression. Okay, so during her preliminary examination, she reported feeling sad moods, low energy, feeling of hopelessness, and fear of leaving her home, even if it were for just like simple daily activities that everyone should be able to do normally. But she didn't experience any hallucinations or paranoia or violent thoughts of or violent thoughts towards herself or towards others. So that was a positive thing. So next, the Mass General doctors ran a series of tests to figure out what was causing her depression and anxiety to worsen so suddenly. So they ran a series of tests, but all standard tests came back normal. However, behavioral analyses did indicate to the doctors that she was easily distracted and her thought process was kind of tangential, but it was easily redirected. So all of those symptoms were consistent with her pre-existing bipolar disorder mental illness, but the exam did reveal diffuse inspiratory and expiratory wheezing, which prompted them to run a chest CT.
So the chest CT showed a new tissue mass in the right breast that was not present 16 months earlier, and the brain MRI was very normal, which will be very important in her diagnosis later on. And moving on to pathology, histology showed a difference between the carcinoma cells in her right breast and those in her from her early lung tumor, and that suggests that this could be primary breast cancer rather than secondary lung cancer. So she was diagnosed with primary breast adenocarcinoma, which is a carcinoma that arises in glandular tissues, such as mammary glands, prostate glands, and others. And the oncologists recommended a lumpectomy to be done with lymph node biopsy. However, the patient's depression worsened, and she didn't schedule for surgery. So we know that this patient has had a long history of mental illness, but it is very important to also look into any cancer-related causes of her depression, specifically brain metastasis. These actually change neuronal functions, which could affect her moods, thereby causing depression. We know that cancer also involves a lot of pain and fatigue, which could worsen her depression. However, her MRI came out normal, so any organic causes of her depression were ruled out. Cancer is also a very serious stressor. It could lead to distress and grief, could lead to adjustment disorder and maladaptive coping, as well as substance use, which we know our patient is struggling with. So there could also be any secondary depressive syndromes unrelated to cancer, as well as any coexisting psychiatric disorders such as bipolar disorder, which she was diagnosed with, schizophrenia spectrum disorders, and any other disorders that involve depressive symptoms. There were no psychotic symptoms observed in our patients, so schizophrenia was also ruled out. So for this case, the main problem is how can doctors treat cancer in patients with mental illness? And for this patient, her mental illness is severe enough to interfere with her cancer treatment. She has manic features such as impulsivity, which could lead to poor decision making and inconsistent choices. She has had a high burden of depression for a long time, which could factor into whether or not she decides to have her treatment. She can also easily give up when faced with these situations because of feelings of hopelessness that arise due to depression. Cognitive difficulties such as ADHD, which she was diagnosed with, could also impair planning and problem solving. The patient was diagnosed with bipolar I disorder, early stage breast adenocarcinoma, ADHD, and tobacco addiction. She finally agreed to have a lumpectomy done with lymph node biopsy and to also continue with her electroconvulsive therapy.
All right,
right, so I'm going to talk about the management of her breast cancer. And this slide is just a general overview of the whole breast cancer part that she was dealing with. So between stage 1 and stage 3 breast cancer, the goal is to cure it. And there's a 98% survival rate for the stage 2 breast cancer that she has. So generally that's a pretty good prognosis, but for her specifically, she had a lot of other mental issues going on, so they didn't know exactly how much this might reoccur, what her own survival rate might be. So the radiation plan for her was a little bit changed from the usual strategy that they have. So she was going to get a mastectomy, which is the usual strategy that they would have for treating this stage 2 breast cancer. But she decided that she didn't want to have that surgery. She decided that if she was going to have a mastectomy, she wasn't going to follow through with all the other radiation treatment which she was supposed to have. So she ended up doing a standard lobectomy, which is the only one that she said she was going to do at this stage of her depression. So they decided that that would be okay. The only problem is that it's going to have a higher rate of recurrence. So then the radiation plan that they have after that for chemotherapy was also a little changed because she was having some problems making her weekly appointments. She didn't want to go into the office as much because she wanted a good window of time because she was a little worried that she'd be able to make it into the office with her depression, because there were some times that she was worried that she wouldn't be able to make it in on time and that her mood was, she was not going to want to be in there. So usually, here's like a graph that shows a few different radiation plans for various patients. The first 3 are fairly common. Those are the standard plan for patients without mental illness. So usually that'll be a daily regimen of say 6 weeks or 4 weeks right there. But then the last one on the end is the one that they decided for her, which is one that they don't usually do for most patients, but one that works for her. So they had to compensate for her a little bit there. But she goes in there every week, once a week, for 5 weeks. So that was a way that they could try to make her come in and actually get to her appointments. So also a big decision to make with this treatment of her breast cancer was the decision of how much local therapy and how much systematic therapy they were going to use. So basically when they make the decision of that, they're going to look at a wide range of options for her, and they're first going to start with the prognosis. So basically thinking about the whole course of the disease and how it's going to play out over time. And if that's okay for the decision that they're going to use, they're going to keep thinking about it, and if she's going to benefit from therapy, if there's going to be any benefit for her mental illness and also to her cancer, they're going to keep trying to go through with that. And also toxicity of the disease, what are the various risks that are involved with it. One thing that the patient did not want to deal with was risk. She said that if she was going into the office, she did not want to deal with any risk involved. She wanted to feel as safe and as comfortable when she was dealing with her cancer. So basically just talking about what local therapy and systematic therapy is. Local therapy is controlling the cancer cells in a local area. So examples of that is going to be surgery. For example, with a lumpectomy, you're going to take out the local part of the cancer. You're not going to affect the whole body. And then also local radiation too is an example of that they used. And then systematic therapy is more when they're using the whole body to try to control the cancer. So that's going to be chemotherapy, and it's also going to be sort of whole body like hormonal regimens too. So here are some challenges that are presented, especially ones that are common with mentally ill patients dealing with cancer. So challenges that occur with all patients, but are maybe even worse with these people that are mentally ill. One example is how much information do we provide to the patient? If you provide too much information to a patient that might not be able to handle that much information or is not making their appointments, it's going to be too overwhelming for them, and it's not going to help them with the treatment of the disease. And then also a range of options to discuss. If they have too many options, then there's going to be some options that are not going to work for the patient, and again, ones that they're not going to understand because they're not there all the time. And also, there's some challenges that arise with mentally ill patients that are ones that are not as common with just common cancer patients without mental illnesses. And some of these are how much capacity does the patient have to inform consent. It's harder to have consent from a patient who is mentally unstable because they might have a decision that changes over time. If they make a decision at one point, then they might totally have a different idea of that decision at a different point and might want to change the course of their treatment. And how stable are the patient's preferences over time? Again, that's a similar idea. Over time, their preferences for the treatment of the disease is going to change. And also the time required to deal with the patient is going to vary based on how their mental state is at the time. And that's definitely something to consider as well. And then will the patient miss their visits? This patient was missing a lot of her visits, and that's going to affect how long it is going to take to treat it and also what they're going to use for treatment. And then communicating with the psychiatrist is also a big deal because the psychiatrist is often in a different part of the hospital or a different clinic altogether. So the communication between the oncologist and the psychiatrist can be difficult, especially when the patient is mentally ill. So the answer to all these challenges is going to be address the patient's needs first. They're going to need to make sure that the patient is going to make the appointments and is willing to do the course of treatment. And if they're not going to do that, they're not going to cure anything. They have to make sure that it's working for them first. So here's kind of an overview of bipolar disorder and how their mood can change over time. So if we're thinking about the treatment of the disease, we want to have her more in the middle line right there instead of going into the other areas. Because if she's at a major depressive state or in a state of mania, those are the times when she's going to change the decision of her treatment. And so you're going to want the doctors wanted to try to deal with the mental disorders first so that she wasn't going to change her decision over time. All right, so for patient engagement, some of the things they had to think about. So understanding the patient's priorities were a big deal because the patient, she didn't really want to go under surgery at the time. And she was also a little worried about what was going to happen to her husband because they were the only two there and they didn't have much social support between them besides her. And then also remembering the patient's strengths and vulnerabilities, sorry. And so some of her strengths are that she can build a relationship with the doctors, and she also, she has had cancer before, and she has survived it, so she knows that she can do it again, even if she's a little worried about it. It's somewhere in here that she can still do it again. And then optimizing the psychiatric systems and functioning. So again, trying to deal with the symptoms of the mental illness before dealing with the ones for the cancer is going to be a big deal in making sure that she's living her life that way. And then identifying barriers to treatment with a patient-centric approach. So they're going to try to figure out reasons why she's not coming into the office and what's stopping her from going there. And they're going to make sure that she is at a mental state that she can make it to those appointments. And so here's a quote from the patient, kind of explaining why she wasn't making these appointments. And she's saying she's exhausted all the time and I can't get here. I have no motivation. I'm scared. So she was actually scared to be going into these appointments because she felt stigmatized there. She was scared to be dealing with it again. She just was not in a comfortable state. So they really need to get her at a point where she was comfortable to be there. And so this is just a really quick overview of dealing with psychiatric illness and also the medical illness at the same time. So she's over in that gray quadrant at the top that says she needs a new model, in that she has to deal with both these illnesses at the same time. And there's no real way in the medical system to have the same person dealing with these things. You need to have multiple people involved in the process because it's so complex. And then so they decided what they were going to do to try to help her get to these appointments and have her feel comfortable in this dealing with the cancer, is that she's going to have a cancer navigator. So the cancer navigator is a person that's going to help connect all the dots. They're going to be meeting with the oncologist, they're going to be meeting with the psychiatrist, and going to be meeting with the patient as well to make sure that the patient is going to these appointments and treating her disease in a good timeline. So they're going to guide her through the barriers in the healthcare system and make her at a more comfortable place where she can do that. So here's a really good quote from one of the oncologists of working with the Cancer Navigator. And the Cancer Navigator actually worked with the medical professionals a lot to try to make this happen. So in our specialized world, we can get frustrated when patients don't follow our logic. It takes patience, perseverance, and extraordinary caring professionals. It was a matter of not giving up on her and the amazing resource of the Cancer Navigator and the personal touch she provides, which makes all the difference in those who are underserved or maybe difficult to serve. And so this is just a little quick infographic. This is not from this patient. There wasn't one that we had for this specific case, but this one just shows really quick. So when patients didn't have a navigator, they were less likely to they had a lower 5-year survival rate, which in this particular case it was 39%, and then when they did, it was 70%. That's an almost double increase, which is a huge deal in helping treat these patients. So here's just a little summary of the treatment of the disease. So in this first box here with the diagnosis, that's when they're trying to make the decision that she's gonna undergo surgery. So in the next one, the consultation, that's when they decide they want to have a lumpectomy, but the patient wasn't making enough patients to deal with it. So then they bring in the Cancer Navigator, and they're starting to make all these connections between all these people, especially with the patient, to try to get what the patient wants. And then they all collaborate at the end, and that's how they get to the treatment goal, is that everyone's in the loop. They all know exactly what they want for the patient, and the patient's comfortable being there. And that is it.